So here's our second short video on nerves of the upper limb. In this scenario, a 65-year-old female patient presents to the emergency department after a fall, and as you can see, she suffered an oblique fracture of the mid-shaft of the humerus. I just want you to pause the video, see if you can figure out which nerve is affected here, and then what the clinical features of this nerve palsy might be. So of course, this is a radial nerve palsy. The radial nerve is the main nerve of the extensor compartments of the upper limb, both the arm and the forearm. It arises, it is provided, fibers are provided from all the brachial plexus roots, that is C5 to T1, and it is the main terminal branch of the posterior cord of the brachial plexus. The nerve emerges from below teres major, running posterior to the axillary artery, and then leaves the artery to run very deep, deep to all of the muscles, and actually in contact with the humerus along the spiral groove. It winds its way across the posterior surface of the humerus, ending up laterally, and then it pierces the lateral intermuscular septum to cross into the elbow anterior to the lateral epicondyle, across the lateral aspect of the antecubital fossa. As it enters the forearm, it breaks up into two branches: the superficial branch, which is mostly cutaneous, and the deep branch, which is muscular. The superficial branch runs deep to brachioradialis, runs down the lateral aspect of the forearm, and then enters the hand across the wrist by breaking up into its terminal branches and running across the anatomical snuff box into the hand, supplying the dorsum of the hand, bearing in mind the only part of the hand that is purely supplied by the radial nerve is the dorsal aspect of the first interdigital space. That's the space between the thumb and the index finger. The motor branch winds around the neck of the radius to enter the dorsal compartment, and then runs between the deep and superficial extensor muscles of the forearm, supplying these, and ends at the wrist, supplying some sensation to the wrist and the back of the forearm as well. It supplies all extensors of the elbow, wrist and fingers, except for the few muscles that are innervated by the axillary nerve. It also provides sensation to the posterior arm and forearm and the dorsal radial 3.5 fingers. The medial 1.5 fingers dorsally are supplied by the ulnar nerve. A lesion of the radial nerve will lead to a wrist drop and numbness to the dorsal aspect of the forearm and back of the hand. But as we said, the only place that is reliably supplied only by the radial nerve is the first interdigital space. So if we compress the nerve against the humerus, or if it's damaged in association with a humeral fracture, we can get injuries. So that would include a fracture of the midshaft of the humerus, or Saturday night palsy, where a drunk person is leaning on a chair sleeping and compressing the posterior aspect of the arm. There can be injuries to the deep branch of the radial nerve as it crosses over the neck of the radius if you have a severely displaced radial head fracture as well. So that was the radial nerve. If you have any questions, you can bring them up at class. So we're also going to look at these nerves, the musculocutaneous, median, and ulnar nerve. Thank you for listening.